Hello everybody, my name's Michael Heuninckx here with Solheim Enterprises, and today I'm going to teach you guys how to master the ventilator. It's not as scary as it sounds, and I promise you I will break it down section by section, setting by setting, so you'll be able to feel comfortable setting the ventilator on your newly intubated patient. Kind of as an overview here, what are we going to talk about in this lecture? We're going to discuss indications for intubation. We're going to go over specifically definitions relating to each setting on the ventilator. We're going to go over ABGs, different modes of ventilation, and we'll wrap it up here with some case studies. Okay, let's jump into this. Indications for intubation. Our intubated patients had trouble doing one of two things or even both, oxygenating or ventilating. Common reasons why: sepsis, trauma, even ARDS, pneumonia, asthma. All of these diagnoses can lead to difficulty with oxygenation and ventilation, causing them to be intubated. If we look at this diagram over here, we're going to see a ventilator, and we look at it and we're so confused. What does all of this mean? What are the proper settings? What is it going to control? Where do I even start? No worries, we'll break it all down definition by definition, and we'll get through it. Let's get started with our first definition, that being tidal volume. Tidal volume is going to be the amount of air in mLs that is installed into the lungs. The equation that I want you guys to use for this is a lung protective strategy, and that's going to be 6 mLs per kg. When we're figuring out their weight in kilograms, we want to make sure that we use their ideal body weight, not what their actual weight in kilograms is at the time that you are taking care of that patient. For males, to figure out an ideal body weight, we're going to use the equation 50 plus 2.3 times their height in inches minus 60. And for females, we're going to use the equation 45.5 plus 2.3 times their height in inches minus 60. And that's going to give us in kilograms their ideal body weight that we'll be able to then plug into our original equation of 6 mLs per kg. And this is going to be the starting point for your patient and a way for you to know exactly what number to plug into the ventilator when you're setting their tidal volume. Now that we have our starting point of tidal volume, we need to know now what is that going to do if I increase that volume or decrease that volume. An indication for increasing that tidal volume is if our CO2 was too high. Because what do we want to do? Take a larger breath in, so we take a larger breath out. Every time that we exhale, we're exhaling more CO2. So the larger volume you inhale, the larger volume you exhale, and that is going to drop your CO2. If maybe that initial setting is dropping your CO2 too much and now we need to increase that number, we're just going to decrease the volume that we're putting into the lungs. So if our CO2 is too low, we can decrease our tidal volume. That then will be a smaller breath that we're taking and a smaller breath then that we're exhaling. If we're exhaling less CO2, then that means that we'll have more CO2 within our body. Now that we've got our tidal volume figured out, let's move on to respiratory rate. A normal respiratory rate is going to be anywhere between 8 to 12 breaths per minute. You can set the ventilator to one of those settings initially, but then we're going to be looking back at our ABG to figure out if we want to increase that respiratory rate or decrease that respiratory rate. And you guessed it, just like tidal volume, we're going to be manipulating our CO2 with whether we increase or decrease our respiratory rate. So if we increase our respiratory rate, we're going to do what? We're going to blow off more CO2. And then the exact opposite of that, if we decrease our respiratory rate, how many breaths that we're taking in a minute, we're going to do what to our CO2? If we decrease the times that we're taking a breath, what's going to happen? Our CO2 then is going to rise because we're blowing off less volume in a minute. Our next setting, inspiratory pressure. When we're setting our inspiratory pressure, that's going to be the initial pressure that we're giving and delivering to our patients that then ultimately is going to give us a tidal volume. And now that we understand the role of a tidal volume, if we increase our inspiratory pressure, that's subsequently going to increase our tidal volume. But if we decrease our inspiratory pressure, that's going to, you got it, decrease our tidal volumes as well. And just like the slide before, if we increase our tidal volume, we're going to blow off more CO2. If we decrease our tidal volume, we're going to hold on to more CO2 because less of a volume is being blown off. The next setting that we're going to talk about is inspiratory time, and that's going to be the time that you set the ventilator to deliver a breath in seconds. If we increase our inspiratory time, we're going to increase our PaO2 and CO2, and if we decrease our inspiratory time, we're going to decrease our PaO2 and CO2. And where that comes into play is setting our inspiratory to expiratory ratio. You're not going to necessarily manipulate this number. How you're going to manipulate it is by increasing or decreasing the inspiratory time. Physiologically, you and I right now are spending twice as long exhaling as we are inhaling. And if you just take a couple seconds to just sit there and take a breath in and then you take a breath out, you might not have even realized that you are breathing out or expiring longer than you're taking a breath in. But for different reasons, if patients were having difficulty oxygenating and you increase their inspiratory time for that breath, you're going to bring that ratio of inspiration to expiration closer together. So what that's going to do is you're going to inspire, hold that breath in longer, allowing for more oxygen to diffuse across those alveolar units before you're exhaling. But if you're inhaling in that respiratory cycle longer than you're exhaling, you're bringing those two times closer together, then you're going to subsequently increase your CO2, because if you're exhaling for a shorter period of time, then that gives you less time to blow off CO2, which is why increasing your inspiratory time not only increases your PaO2, but also increases your CO2. And for some patients, we even will inverse the I to E, inspiratory-expiratory ratio, because they are having such difficulty oxygenating that we're going to inhale for twice as long as we do exhale. And then we take another breath in, exhale, take another breath in, and that's all allowing for more oxygen to stay in those alveolar units to hopefully diffuse across to systemic circulation. But we're also watching out, again, we're decreasing that expiratory time, so what's that going to do? Really be increasing our patient's CO2. But that's where we walk the balance of how are we going to manipulate this ventilator to the specific needs of the patient. And when in my practice, when we inverse that I to E ratio is going to be for our patients who are in ARDS. Okay, let's move on to PEEP. PEEP stands for peak end expiratory pressure. When we're setting our PEEP, that's going to be at end expiration. What pressure is the ventilator going to be delivering to keep those alveolar units open? So by the time that your patient takes the next breath, they're already open, they did not collapse, and the breath will be able to get in fully to the entire, every part of the lungs to be able to then be ready to catch that oxygen to diffuse across that alveolar unit. At a minimum, for our ventilated patients, we're going to have our PEEP set to 5. But if we were having trouble with oxygenating our patients, our PaO2 was low, we're going to increase that PEEP. The more PEEP that we have on, that at the end of a breath is going to be priming our lungs more and giving the lungs more force so those alveolar units do not close. What we have to be very conscious of, though, is as we're increasing that PEEP, that peak end expiratory pressure, that's increasing the intrathoracic volume and pressure within our chest. As those pressures rise, we might see our patient's blood pressure decrease because externally that extra pressure that's on the heart from the lungs is going to be tamponading the heart externally, much like it would in a pericardial tamponade situation, but the patients don't have it at this point. We're externally doing that from the lungs by increasing our PEEP so much. So be very careful as you're increasing your patient's PEEP to what is the hemodynamic effects that it's having on our patients. Are they still maintaining an adequate blood pressure?